फ्रेंड्स, आज हम बात करेंगे पेरिनेटल एस्फिक्सिया के बारे में. देयर आर 4 डेफिनेशंस. WHO सेज कि व्हेन देयर इज फेलियर टू इनिशिएट एंड देन सस्टेन ब्रीदिंग इज पेरिनेटल एस्फिक्सिया. National Neonatal Perinatal Database says there is moderate perinatal asphyxia and then there is severe perinatal asphyxia. Moderate means at 1 minute of life. ठीक है, at 1 minute of life either there is gasping respiration or a Apgar score of less than 7 between 4 to 6. ठीक है. Severe perinatal asphyxia is when there is no breathing with Apgar score of 0 to 3 at 1 minute of life. Then the third one is by the American Academy of Pediatrics. It says there are 4 criteria and it need to fulfill all the 4 criteria. First one is there has to be metabolic acidosis. Either metabolic acidosis or mixed acidosis, mixed acidemia, right? The second one is persistence of low Apgar score of less than 3 at 5 minutes of life, right? Apgar low, less than 3 at 5 minutes of life. Third is there has to be neurological signs in the form of seizures, in the form of encephalopathy, and in the form of tone abnormalities, right? Then last one is here, there has to be evidence of multi-organ involvement. Multi-organ involvement, there is involvement of the brain, either brain, then heart, then lungs can be there, then kidneys are there, then intestines are there. So all the 4 criteria need to be fulfilled as per American Academy of Pediatrics. Now, what is the clinical definition of perinatal asphyxia? Clinically, there has to be any one of the following, right? Any one of the following. The first of which is the clinical definition of perinatal asphyxia. How will clinically categorize the patient to be perinatal asphyxia? Any one of the following criteria has to be fulfilled, right? One is that either there is gasping or ineffective breathing, right? Breathing is not proper at 1 minute of life, or either gasping, either ineffective breathing, or there is lack of breathing, right? No breathing at all. Then requirement of positive pressure ventilation of more than 1 minute. Then last is your persistence of low Apgar score. Low Apgar at 5 minute. At 5 minute of less than 3. So any one of the following criteria, either baby has to be gasping, या ineffective breathing, या lack of breathing at 1 minute of life, या at 5 minutes of life persistent of the low Apgar score less than 3, or there is requirement of the positive pressure ventilation of more than 1 minute. If any one of the following is present, we'll categorize the patient to be perinatal asphyxia. Perinatal asphyxia, that is lack of oxygen. There is decreased supply of oxygen to the vital organs of the body, to brain, to your heart, to your lungs, to your kidney, and to your intestines. So while we are managing a newborn with perinatal asphyxia, our focus is to take care of all the systemic manifestations, all the multi-organ manifestations of your perinatal asphyxia. Now, when because of asphyxia, there is involvement of the brain, the CNS involvement of the perinatal asphyxia is called as HI, that is hypoxic ischemic encephalopathy, right? And when we manage a patient of perinatal asphyxia, our prime concern is to focus on CNS as well, because while managing HI, it will actually determine the long-term neurological sequelae, how well we are managing the patient's HI, long-term neurological sequelae. Okay. Now, what is actually the evolution of HI? What is the evolution of HI? What happens when there is lack of supply of oxygen to the brain as a result of hypoxic ischemic insult. So this is the area which is actually which is deprived of the oxygen. ठीक है? So this is the necrotic patch जिसको हम कहते हैं penumbra, right? And there is surrounding area which is ischemic. Now period, there is a window period when there is ischemia and when reperfusion is established, right? Even after reperfusion is established, there is release of free radicals from the surrounding necrotic area. Then there is free radical mediator programmed cell death, and then that results into the manifestations of your ischemic insult of the time gap is actually very important when there is ischemic insult and when there is reperfusion. This window period is between 6 to 24 hours because जितनी जल्दी reperfusion establish होगी, that actually will determine the long term neurological sequelae in the. बात करेंगे कि as a result of perinatal asphyxia क्या होता है कि perinatal asphyxia मतलब lack of oxygen to all the vital organs of the body. अब इसकी वजह से different organs में क्या क्या manifestations होती है. CNS में सबसे पहले तो HI hypoxic ischemic encephalopathy, seizures हो सकते हैं, right? Then you can have long term न्यूरोलॉजिकल सीक्वले हो सकते हैं. अगर प्रीटर्म बेबी है उसमें इंट्रावेंट्रिकुलर हैमरेज हो सकता है, पेरीवेंट्रिकुलर ल्यूकोमलेशिया हो सकता है. हार्ट में क्या होगा, हार्ट में देयर कैन बी ईदर मायोकार्डियल डिसफंक्शन, ठीक है, मायोकार्डियल डिसफंक्शन, देयर कैन बी ईदर वेल्वुलर डिसफंक्शन, then there can be rhythm abnormalities like arrhythmias can happen, right? And there can be congestive heart failure. In lungs, what happens? There is respiratory failure, there is delayed adaptation, then there is meconium aspiration, then there is surfactant deprivation, and then there is surfactant deprivation, and then there is persistent pulmonary hypertension of newborn, right? In kidneys, we have got acute tubular necrosis हो सकती है, then we can have hematuria, ठीक है, acute tubular necrosis is there, hematuria is there, and then in gut we can have gut or intestine, we can have necrotizing enterocolitis, neck is there, right? Then we can have hepatic dysfunction, involvement of the liver is also there. Hematological abnormalities includes decrease in the platelet count, that is the thrombocytopenia, and then there is bleeding, or there is coagulation abnormalities landing up into DIC, consumptive coagulopathy can be there. Then metabolic abnormalities can be, initially will start with the metabolic acidosis can happen. Then there is decreased glucose level, that is hypoglycemia. Then there is hypocalcemia. Then there is hyponatremia. All these things can happen, and while we are managing a patient of perinatal asphyxia, we need to focus on all these things, that all these things can happen to the patient, so we need to monitor patient accordingly and manage accordingly and give the support of hypoxic ischemic encephalopathy. There are two staging. One is your Sarnet and Sarnet, which is actually very detailed classification, right? Another, that Levine staging now will take into account 5 parameters. It is classroom classroom SST. So C is consciousness, then respiration, suck, seizures and tone. In stage 1, 2 and 3. Stage 1 में consciousness, baby is irritable. Stage 2, baby is lethargic, and then baby is comatose. Stage 3. Respiration, in stage 1 what happens? Baby is having spontaneous breathing, but in stage 2 baby is having either irregular or periodic breathing. In stage 3 baby is not able to sustain the spontaneous breathing. Suck, in stage 1 there is poor suck. Baby is able to suck but the suck is poor. But in stage 2 baby is not able to suck, and in stage 3 there is absent suck. Now seizures. In stage 1 there are no seizures. In stage 2 seizures are there, but in stage 3 seizures are either prolonged or it can be refractory. Tone. In stage 1 the tone is decreased. In stage 2 tone is furthermore decrease, there is marked hypotonia, and in stage 3 baby is flaccid, right? These are the 5 parameters that we take into consideration during clinical management of perinatal asphyxia, right? And it need to be revised every 8 to 12 hours. 8 to 12 hours leave-in staging need to be repeated, so that we can actually infer from this ki whether the baby is improving or baby is deteriorating, right? It helps us to assess whether the baby is improving or your baby is deteriorating based upon the clinical management of perinatal asphyxia. कैसे manage करना है? Babies who are at risk of perinatal asphyxia, as soon as babies are born, will start from the delivery room only, right? In the delivery room only, what we have to do immediately, as soon as the baby is born, we'll do the oral suctioning. Oral suctioning followed by the nasal suctioning, right? This is the order. पहले नेजल नहीं करना है, बिकॉज अगर बेबी के मुंह में सिक्रीशंस होंगी तो देर आर चांसेस ऑफ एस्पिरेशंस, राइट? तो पहले ओरल सक्शनिंग करनी है, उसके बाद नेजल सक्शनिंग करनी है, बेबी को क्लीन करना है और बेबी को ऑक्सीजन प्रोवाइड करना है. ऑक्सीजन अगर टर्म बेबी है विच इज बॉर्न फॉर मोर देन 35 वीक्स, राइट, 35 वीक्स से ज़्यादा है बेबी, तो 21% ऑफ ऑक्सीजन उसको इनिशियली प्रोवाइड करना है. अगर बेबी इज लेस देन 35 वीक्स तो इनिशियल पे ही यू कैन टाइट्रेट द ऑक्सीजन टू 21 to 35% in order to maintain the saturation between 90 to your target saturation is 90 to 95% तक maintain करना, right? And when you observe any one of the following, and you'll do the Apgar scoring you have done. अगर Apgar score जो है it is less than 3 at 1 minute of life, right? या पॉजिटिव प्रेशर वेंटिलेशन दी है इन द फॉर्म ऑफ एम्बू आपने किया है बेबी को फॉर मोर देन 1 minute और 60 seconds, राइट? और persistence of low Apgar score or even persistent of low Apgar score at 5 minutes of life is also an indication. Then is you have given chest compressions to the baby, you have to immediately shift the baby to NICU. You have to immediately shift the baby to NICU, and then further management continues in the NICU. Phase of management or the main phase of management of perinatal asphyxia begins in the NICU. First thing is you have to maintain the temperature, right? You have to maintain the temperature of the baby between 36.5 to 37.5 degrees Celsius. You have to maintain this temperature. Avoid hypothermia, avoid hyperthermia. So immediately dry the baby and keep the baby under the radiant warmer, right? In order to maintain this temperature, right? Then second is you have to maintain the oxygenation and ventilation, right? You have to maintain oxygenation and ventilation. You have to ensure that saturation of oxygen is between 90 to 95%, right? For this initially you can use the oxygen hood, you can use, है ना? And you can titrate the oxygen levels based upon the requirement in order to maintain the saturation of oxygen between 90 to 95. You can even use the nasal prongs. But in cases, if there is irregular breathing, baby, there is gasping, or there are no spontaneous efforts, right? Then you have to start IPPV, which is positive pressure ventilation. You have to intubate the baby and you have to put the baby on ventilatory support, right? One thing is that we forgot कि as soon as the baby is born na, in the delivery room itself we have to take the cord blood sample. Cord blood has to be taken, sample, arterial, and we have to send for ABG in the heparinized syringe. Whenever there is any deterioration and whenever you are putting the baby on ventilator, so you have to resend the ABG, arterial blood gases, right? Findings of ABG in case of perinatal asphyxia. There is metabolic acidosis with pH of less than 7.35 and there is base deficit which is more than 16 millimoles per liter. If this is the scenario on ABG, it indicates there is long-standing perinatal asphyxia, like it is minutes to hours, right? It's long-standing perinatal asphyxia. But if in case ABG shows respiratory acidosis, right? ABG shows respiratory acidosis. In absence of metabolic acidosis, it shows acute asphyxia. It shows acute asphyxia that can be because of cord prolapse or that can either be because of your abruptio placentae, right? Abruptio placentae. You are doing the repeated ABG, what you have to see and what you have to manage. Your aim is that pH should be between 7.35 to 7.45, right? Second is that your partial pressure of oxygen, it should be between 60 to 90 mm of mercury. And then your partial pressure of CO2 has to be between 35 to 45 millimeters of mercury. Now, avoid hypercarbia and avoid hypocarbia as well. In case if CO2 is more, there is hypercarbia, there will be vasodilatation. Vasodilatation means there is increased blood flow to the brain, that is increased cerebral blood flow. There will be increased cerebral perfusion, there will be increased intracranial pressure, and that can increase the risk of IC bleeds, right? It will increase the risk of IC bleeds. And in case of hypocarbia, there will be further decrease cerebral perfusion. So your aim is to maintain the partial pressure of CO2 between 35 to 45, avoid hypercarbia and avoid hypocarbia. We talked about while managing the perinatal asphyxia, first thing is that we have to maintain the temperature between 36.5 to 37.5 degrees Celsius. Second is we have to maintain the oxygenation and ventilation. As per the requirement, you have to deal with the baby, and then what are the norms that you require actually to maintain on the ABG. Then the third is you have to maintain the perfusion. For normal perfusion, the CRT has to be less than 3 seconds. There has to be no tachycardia. There has to be no metabolic acidosis. And you have to maintain the urine output of more than 1 ml per kg per hour. And there has to be normal blood pressure, right? There has to be normal blood pressure of the baby. Normal blood pressure as per the age specific normal upper range, right? It has to be maintained. In case if the CRT is less than 3 seconds, right, you'll give the bolus of isotonic fluid. Either RL or NS is to be given at the rate of 10 ml per kg over 5 to 10 minutes. You can repeat. If again it is not improving, you can give another bolus, and even after that if baby is not improving, then you have to start the baby on the inotropic support, dopamine or dobutamine. Start the baby, all the babies, those who have Apgar score of less than 3 at primarily less than 4 at 1 minute and less than 7 at 5 minutes of life, or in case the babies are sick, there is respiratory distress, right? There is abnormal tone, the baby is comatose, you have to start the baby on the IV fluids, right? Then another thing is that you don't have to restrict the IV fluids in the baby with perinatal asphyxia, because it can predispose the baby to further hypoperfusion. You have to restrict the IV fluids only if your sodium levels are less than 120 milli equivalent per liter, considering ki SIADH is happening, and that is in order to control that factor, or in case of you have to restrict IV fluids in case of renal failure, right? And the second thing is that now to check for the metabolic parameters, you have to do the ABG. You have to maintain the blood glucose levels. It has to be maintained between 75 to 100 milligram per deciliter, and blood sugar need to be monitored every 6 to 8 hourly for 48 hours, right? Another thing is that you have to maintain the hematocrit. Hematocrit has to be between the 45 to 55%. In case if it is more than 65%, you have to lower it down to 55% by giving NS and performing partial exchange transfusion, right? Partial exchange transfusion. Now, in case if the baby is having seizures, you have to do the management of the seizures. In case when you have to start the feeding, you can initiate the feeding in the baby once the baby is hemodynamically stable. Once the baby is hemodynamically stable, baby has passed the meconium, there is no abdominal distension, right? And bowel sounds are plus, you can initiate the feeding in the baby, either express breast milk, or you can use, if not available, then you can use the formula. Measured formula feed need to be given. You can begin at the rate of 30 ml per kg per day. Now you have to titrate the feed and the fluid accordingly, right? Feed and fluid accordingly. In case of severe perinatal asphyxia, you have to give the 10% of calcium gluconate, right? 10% of calcium gluconate is to be given either in the form of 1:1 dilution with dextrose 5%, 6 hourly, right? Either it can be given this way or in the form of continuous infusion, right? But what is the rate? It has to be given 4 ml per kg, 4 ml per kg per day, right? You have to maintain the calcium levels. It is required to be given for initial 48 hours. Various parameters which need to be monitored in patients with perinatal asphyxia. Number 1 is the neurological status. Neurological status, it need to be assessed every 8 hourly. Every 8 hourly, using your Levine staging. It will assess whether the baby is improving or baby is deteriorating. Number 2 is you have to assess the respiratory. Respiratory status have to be assessed using the Down's score. It has to be done every 3 hourly, right? Then third is cardiovascular status. For cardiovascular status, you need to monitor the CRT. You need to monitor heart rate, pulses, CRT, heart rate, pulses, and then is your pulse oximetry, right? Then is your pulse oximetry. Then you have to, because there are chances of paralytic ileus in patients with perinatal asphyxia, so you have to monitor abdominal girth every 6 hourly. Every 6 hourly abdominal girth has to be monitored, right? And then thereafter you have to monitor the urine output. Urine output need to be monitored. Urine output, your aim is to maintain the urine output of more than 1 ml per kg per hour. You have to monitor the blood glucose levels every 6 hourly for initial 48 hours, and the aim is to maintain blood sugar between 75 to 100. And in case if there is hypoglycemia, then you will start GIR, right? And manage patient accordingly.